Hello doctors, welcome to yet another series on fetal medicine from Jummy Scans. And this time we got a lot of queries and topic suggestions after our initial few videos, and this video we are going to see short and crisp details, practical points on what to do when aneuploidy markers are abnormal during an NT scan. So what do I mean by aneuploidy markers? The main thing which we are going to see today are two things. One is nuchal translucency, the NT, and ductus venosus, because nasal bone is a topic by itself, so it needs a lot of discussion. So we're going to quickly see about these two aneuploidy markers, what happens and what do we need to know when these two goes abnormal. So as usual, let's start with our case history. She is a low-risk primary gravida, 26-year-old. She is married since only 1 year. She is a natural conception and particularly no significant history. She came for a routine first trimester screening, and everything else was fine. The baby was in neutral position, nasal bone was seen, but then the NT was apparently seen a little more prominent than normal. So when we were waiting for the fetus to come to the neutral position and we measured, the CRL was around 6 centimeters for 13 weeks, and the nasal bone, rest of the fetus being normal, but the NT was about 2.5, say around 2.6 or 2.7. So usually when we take NT, or when we call it up, when it goes beyond 2.5 or closer to 3 millimeter, always it's good practice to measure NT 3 times, minimum of 3 times, and take the mean value. So that's how we proceed, we process. And also there are machines nowadays where we get automated NT. So if the baby is in good neutral position, the machine will measure NT for us. We can also correlate it and see if it's correct with a manual NT measurement. So we got NT was slightly on the higher side, say above NT was falling beyond 95th centile for that particular gestation and CRL. Since the rest of the fetus was normal, and because the NT cutoff is always kept as 3 millimeter, we went ahead and gave the blood test. And rest everything, as you can see here, the biochemical markers, if you can over here see that, you can see over here that the beta HCG was around borderline 1.5. Pape was normal. The NT was also, probably the mom was slightly higher than 1.5, which is 1.7. But here, surprisingly, what we thought that the NT was high, we thought that the fetus will fall into the high risk category. But from the age related risk, that is, so 1200 odd mothers, it's come only up till 1137. So it was low risk first trimester screening. So then, before we see what we need to do, is quickly let's correlate with another case scenario, very similar. 27-year-old, no significant history. Again, the NT was around 2.7. And here if you see the cutoff, even though the NT is 2.7, rest of the parameters being absolutely normal, the cutoff is 1600. Then the main question which falls into our mind is, what do we do next? How do we counsel? Do we have to tell them that yes, the NT is slightly on the higher side even though the rest of the fetus is normal? I have taken this graph to show that the NT falls for that particular gestation above 2. If you can check over here, it's above 95th centile, so it's closer to 97 or 98 percentile. Yes, we do have to put it on the report, even though if it is less than 3 millimeter, it is above 95th centile for that particular period of gestation. Then one, we need to know how do we define NT, isn't it? Because there is no specific guideline, because multiple levels, according to ACOG there's one definition, according to Fetal Medicine Foundation. So how do we define NT? So if you see cutoff for earlier CRL, say around 11 to 12 weeks time, the 95th centile forms somewhere around 2.1. So anything above 2 or 2.5, closer to it, we are little concerned. And when you go beyond 13 weeks or closer to 13 plus 6 or something, then the NT cutoff goes up to 2.7 to closer to 3 millimeter. The median value should be anywhere less than 2. But what do we take it as a cutoff? 3 millimeter. And why 3 millimeter? Anything above 3 or 3.5 falls well ahead. That's at the 99th centile. So it's preferable to take the cutoff as 3 millimeter rather than 2 or 2.5 or 2 moms or 3 moms. So it's always preferable to take the NT cutoff as 3 millimeter. Why 3 millimeter? Because substantially or significantly the percentage of aneuploidy rates increases as the NT increases. All of us know this, because above 3 it's around 30%, but when it goes beyond 4 or 5 millimeter, you can see a huge rise in the percentage of aneuploidy. So it's not just chromosomal abnormalities. Number 1, chromosome, then genetic syndromes, 3, you have cardiac anomalies, evolving cardiac anomalies, and 4, skeletal problems. See, these are the 4 main things which we are concerned when we find an increased NT. So irrespective of the CRL, the cutoff is taken as 3 millimeter for easy practice. So when we follow up these patients, that's when the FTS is low risk and the rest of the fetus is structurally normal, you definitely have to call them back. Preferably, yes, all of us have target scan schedules at 19 to 20, but these set of patients, it's preferable to call them back earlier, probably at 16 to 17 weeks. Look for other soft markers, rule out structural abnormalities, mainly cardiac and skeletal. And if rest of the fetus is fine, routine follow-up is definitely advisable rather than putting the patient into very stressful scenario. What are the other structural defects I'm looking for? Obviously, the other structural defects could be limb defects, omphalocele, gastrocrisis, or enlarged stomach, or cystic hygroma, or the main side structural defects which you're looking for. So when we go quickly into practical aspects, aneuploidy markers, when something goes wrong, the first foremost thing, look at the rest of the fetal anatomy. When the rest of the fetal anatomy is normal, go ahead and give them, if the NT is less than 3, go ahead and give the first trimester screening, and based on the first trimester screening, you can follow up the patient. Yes, you can definitely call them back for an early target and fetal echo, and if you identify any cardiac or skeletal abnormality or any other growth restriction or any other structural abnormality, it is definitely worthwhile to do a karyotype QF-PCR, or nowadays for isolated increased NT, we do chromosomal microarray in the same amniotic fluid sample or a CVS sample. NIPT, why I have put as query, is that NIPT does not give us a good wide range of chromosomal aneuploidy coverage. NIPT is primarily more towards Down syndrome screening rather than very highly effective for other chromosomes. So we would always prefer to do an invasive procedure like a CVS or amnio to get into karyotype, full-fledged, or a chromosomal microarray nowadays, which we are doing. Why CMA? Because the yield of chromosomal microarray, that is the accuracy or the extra information which you get through a CMA, is 10 to 11% more when compared to a conventional karyotype. So apart from NT, the other soft markers sometimes, not very occasionally, few times, rarely we come across is ductus venosus. So ductus venosus is always a pattern. This is a normal pattern of the ductus venosus. The rest of the baby over here, a 13-week baby, was absolutely normal. Where you can see here that this pattern, a sawtooth pattern, is a systole, diastole, and the A wave always has a forward flow. But here, if you could see here, the A wave, which is supposed to be a forward flow, is slightly going in the reverse direction. So here, this part, this baby, this is the same fetus. Structurally, the cardiac is normal. The same fetus most of the time had a normal flow, but intermittently it had reversal in A wave. So what happens when you have intermittent reversal in A wave or even A wave reversal during the first 3 months? Again, the formula or the follow-up chart should be to look at the rest of the structures. Rest of the structures were normal, so we had given the patient, accepted the patient to go ahead for first trimester screening. The screening was absolutely low risk, 1 in every 12,000 odd pregnancies. The baby was fine. But is that the case all the time? No, even this fetus had a reversal in A wave. It had NT, which was normal, 1.8, but then, but if I remember, yeah, nasal bone was unossified. So we, even though she is only 27 years old, we gave the FTS because there were only 2 markers, unossified nasal bone and ductus venosus A wave. If you could see here, the risk for Down syndrome was 1:5. So if you can see here why it became 1:5, nasal bone absent, then the HCG was very high, it's twice that of the normal range. PAP borderline around 0.6 and NT was normal. So in spite of her being 27 years old, her age was 1:5, and when we did an amnio, because the patient didn't get back to us, she came back to us probably around 14 to 15 weeks or so to get the reports when she was in hometown, and when we got back to us, we counseled her for amnio, and the amnio showed pure trisomy. I hope that this short video, both on increased NT and ductus A wave reversal, probably could have thrown some light on how we proceed with these fetuses forward. So if in case you have any queries on this video, on this topic, or if you want to make, if you want me to make few short videos on common practical topics on fetal medicine, do text me. We'll be more than happy to take these presentations forward. So see you all. Have a wonderful day. See you all soon in yet another Dialogue web series episode. Until then, take care.